I'll hand over to.
Wonderful. Thank you, Amanda. Let me just get my screen share set up. Right. Can you see my slides clearly, Amanda?
Yes, all fine.
Wonderful. Okay, well, thank you very much for such a lovely welcome. What a fabulous day it's been, and a great opportunity and a great juncture to come to IIH UK and talk about some of the research and the science that's been going on. And I've called it a roundup because I speak to the conference quite regularly, usually on an annual basis, to sort of update on what we've been up to. But I think probably this has been one of the most exciting years that we've had. We have formed this research group probably back over a decade ago now, and it was very small steps initially, but we had a goal in mind, and we are slowly getting towards some of those goals. And research does take time, so it's been really, I think the patience has been brilliant in terms of everybody bearing with us as we started to bring these studies through. But it's really nice to be able to discuss some of them with you today. So as you know, we are based in Birmingham, and this is University Hospital Birmingham, where we have a large IIH service. It's probably one of the biggest internationally now, and we take a lot of regional referrals, but also super-regional referrals. And it's obviously very much like the rest of the NHS. It's suffering now post-COVID and trying to catch up and keep up with appointments. So we are, like many parts of the NHS, struggling in some ways to meet the number of patients that we're trying to look after. This is the rare disease building, the Centre for Rare Disease, where we held some of our clinics. And then this is the university, and we're all on a campus. This is some of my team. And it's really at the university side that we do a lot of the underpinning work. So you can see the questions here that really are at the forefront of our mind. What is the cause of IIH? And how can we make better treatments that will then come through into improving patient care? And the other part of our research is really that interaction with yourselves, with the patient groups, with IIH UK, because without the contributions that you all make to helping us get the right questions asked, to helping us design our studies, to helping us get our patient information read and understandable, and then taking part in our studies, the progress and the steps forward that we make just would not be possible. So it's so important that many of you get engaged in research, and thank you very much for those of you that do. So the question I wanted to start with was that question about thinking, why does IIH occur? And when I sit in clinic and we talk to patients, we often start with this question when patients first get diagnosed, because it does seem a very unfair condition for many. It's a condition that's typically seen in women, and that's 90% plus. It's a condition that's typically seen during childbearing years, so between puberty and menopause, although it can continue post-menopause. And it's often a condition that we see related to those that have increased weight, again, 90% plus, or that have had a weight gain. So there have been these factors that we have cogitated on over the years. And I wanted just to draw some analogies to say that really IIH is one type of condition. We call it idiopathic because we don't yet know exactly the cause, but I think over time we will start to delineate more deep understanding about what's going on. But if you can see at the top of my map here, I've got intracranial hypertension, and one of the branches is idiopathic, which is the condition that we normally talk about. But there are many other things that can look a bit like IIH, which we call secondary intracranial hypertension or pseudotumor cerebri. And these can be conditions where you have too many cells in your brain fluid. Sometimes anemia can cause it, sometimes things like venous thrombosis. And as I'm going to touch on a bit later, long duration spaceflight also causes a condition that can manifest a bit like IIH. So we have lots of different reasons, but for many of these conditions, the consequences is similar. We get the swelling or the risk of swelling at the back of the eye and the propensity to have headaches. So what is the role of hormones in IIH? And one of the studies that's taken us forward has been the one that we've published a couple of years ago now in JCI Insight, and it's been discussed quite a lot in medical circles, but I wanted to try and talk a bit more about that with you today. When we talk about hormones, I've put this really complicated map up to emphasize that there are lots of different hormone pathways. And there are lots of different hormones to measure, and there's lots of different enzymes. Those are the chemicals that change one hormone to another. And this pathway is slightly different in different parts of the body, different organs of the body. It's slightly different in how it works in men and women. It's obviously different in humans to in animals. And the levels of hormones that you have in men and women is different. But that's not to say that some hormones are exclusively in men and some are exclusively in women. So I want to show you this one over here, which is testosterone, which I'm going to talk a bit more about. These ones over here are called androgens. They're types of hormones that we usually see at higher levels in men, but they can also occur in women. So our study on one slide was a study that looked at what the hormone signature was. That is the hormone pattern in IIH. And we wanted to know if it was different to other women of a similar weight and of a similar age, which we call our controls. And we wanted to know if the hormone pattern was also different to a similar condition called polycystic ovarian syndrome. And again, this is a condition that's really mostly found in young women of childbearing age who have increased weight. So we said to ourselves, well, what if the hormones are the same as PCOS, or is it going to be different? And is it going to be different to controls? And we used some different techniques that had been used in the past. In the past, it had been typically that you would use a technique called a radioimmunoassay, and you might look at one of those particular hormones on that massive map that I showed you. But in our study, we were able to look at a whole bunch of hormones all together in one sample. So we were able to get a lot more information all at once. And we did this in urine samples and in blood samples and in spinal fluid samples. And we had some really, really wonderful patients that participated to get us those samples, along with obviously having to map out exactly what their IIH was like at the time. So they had to have their eye tests and their headache testing and all of that sort of thing. And in a nutshell, what we found was that IIH patients do have different hormones. They are very different to control patients of the same age, weight, and gender, but they are also different to patients with polycystic ovarian syndrome. So this group in purple here with PCOS, they have higher levels of something called androstenedione in their blood, which is sometimes a precursor of the androgen pathway. But it was very different in IIH. What IIH patients had was significantly high levels of this compound called testosterone, which some of you may hear about as being high in males typically, but that's not to say that women don't have it. Now, we didn't find that the hormone was as high as you find it in men, but it was certainly higher than you usually find in a woman. We also found that those group of hormones, including testosterone, was high in the brain fluid, and that the enzymes, that's the chemicals that change one hormone to another, the activity of those chemicals was also high. So we thought, well, is this something that we've just observed, or how important could it be to the overall control of brain pressure? And the way that we often start unpicking that as a scientist is we start with what we call in vivo studies, which means we study cells in a dish in a laboratory. And we have a system where we can look at cells from the choroid plexus, which is the part of the brain that makes the brain fluid. And we have a system in a dish where we can get an idea of brain fluid production. That's the CSF production. And what we were able to show in this study was that that hormone testosterone could make and could drive the system and make the cells produce more brain fluid. So we were able to start to bring a link between this very different hormone pattern that we'd seen in IIH and why that might be affecting brain pressure and brain pressure regulation. So it's the beginning of a story. And then from that, we have lots more questions. We want to know why the testosterone is high, which tissues are producing the testosterone. But the reason that we have all these additional questions is because then we want to think, well, how does this help us? And in the future, what we'd like to think about is how we could then maybe target, that means potentially block parts of that hormone pathways, so that we wouldn't make so much testosterone. So if we go back to this great big map on the slide before, could we make medicines that would block some of these enzymes and some of these pathways so that we could stop patients producing so much of this hormone that seems to be driving the brain fluid production? So it's showing really how we can use the patient samples that we take with great care and with great contribution from yourselves, and make small steps to understanding cause, and how in the future, by knowing more about the cause of a disease, we can start to make medicines that will target the cause of a disease. So that's a story in progress, and much of what we do is in progress. I wanted to talk about adipose tissue, and some people might have referred to that as fat tissue. It's the tissue that we have under our skin that forms that layer of fat around our legs and our arms and our abdomens, our tummies. And one thing that had come up quite regularly in our conferences with the other doctors, both here and abroad, and with patients, was to sort of say, well, is the tissue different in IIH? Is it contributing to the disease? Is IIH causing changes in that tissue, or is that tissue causing changes in IIH? And indeed, we're going to be looking at that adipose tissue to see how it may be producing more hormones and more of that testosterone that I've just been speaking about. But that's work in progress. But the first thing that we did was to say, well, is the place that you have the adipose tissue different in IIH? So the distribution, the place where you collect the tissue. And what we found was that generally, the adipose tissue was most common in the central area. So that's the tummy area. But what was even more important was that, was that tummy fat very closely and statistically was associated with the degree of elevation of brain pressure. So put very simply, the more tummy fat you would have, the higher your brain pressure would be. So that was important to us because also tummy fat, distribution of tummy fat is important in other diseases such as diabetes and can be associated with future risk of complications such as stroke and heart attacks. So it was very important to start understanding where the fat tissue is typically located so we can think about what other diseases might be important in IIH. What we also wanted to know was whether patients were more at risk of other conditions that we associate with high weight. So increased weight is also associated with a higher risk of, for example, diabetes. And that's a part of a condition called a metabolic syndrome. So diabetes is a condition where you have a difficulty in controlling your levels of sugar in your blood, usually in older life because you don't produce enough insulin. So we wanted to see if IIH patients may have that tendency as well. And we thought that because other conditions where there's increased weight do have that tendency. So for example, polycystic ovarian syndrome has a tendency to have problems controlling sugar levels, and that's through insulin resistance. So again, in this was a very large study where we put several cohorts that we had been collected and biobanking over the years. And again, many patients contributed to this data, and we had to very carefully match it to control subjects who again didn't have IIH, but were the same weight, the same gender, and the same age. So the choosing of the groups is all important in doing the accurate research. But what we found is that IIH patients do indeed have an early tendency towards diabetes. They don't have diabetes or pre-diabetes, but these blood tests in these young patients show they are at risk of insulin resistance. And because we'd compared it to patients of a similar weight, we could conclude that this wasn't driven by weight. This was driven by other factors to do with their IIH. We went on to look a bit more at the adipose tissue, the fat tissue, to understand how it's behaving in a patient with IIH. And this was quite complicated studies to go through. But first of all, what we did was we looked at the genetics, what we call the transcription in the adipose tissue. And we had to collect adipose or fat samples from our patients going through our studies, but also from patients that didn't have IIH. And we collected the two different types of fat tissue. One is the fat that's just under the skin. And one of the other type of fat tissue is the one that's actually right in the abdominal cavity that goes on top of your organs. So very, very invasive to get that. That was all done at the time of bariatric surgery. And that's something that you can't take very easily. So again, this was all done with a great deal of care and skill by some very wonderful surgeons who were participating in the study, and some very wonderful patients who are having surgeries anyway and were happy to give us a sample. So we collected these samples from our controls and from our IIH patients, and we looked at the gene expression. And we found that the IIH adipose tissue had a very different pattern of gene expression compared to the controls. And then when we went to look more carefully at what was different, we saw that actually the main difference in the adipose tissue was that the fat cells were primed or programmed to create and gain more weight. So these tissues behave in a different way and are driven and primed to be more likely to gain weight. And I think that's a really important feature that we found in the disease. Going from the genes, we then went further forward, as we do in science, to understand how this functionally affected what was actually going on, the metabolism, what actually occurs in that little adipose tissue cell, so in that fat cell, what's going on. And we found that as a result of these gene changes, there was very different processes going on in the fat cell, which meant that the metabolism was very dysregulated. And so I think we can conclude from this study that the adipose, or the fat tissue in IH patients, is different to controls. It's primed towards weight gain, and it functions in a very different and metabolically different way to the average control person who's the same age, gender, and BMI. So a beginnings of an understanding that this disease is not just a disease of the brain and the eye, but something very profound is going on even at the level of the fat tissue, which is making the patients more prone to weight gain and be prone to insulin resistance and early diabetic signals. And this is a summary that you can see. And if you want to look up any of our papers, they are mostly open access and can be seen on the internet if you put in the authors and the papers there. And we looked again at this paper for those that are interested, also at leptin, which is another chemical which is related to, it's called an adipokine, and it can control hunger levels, and it can control all sorts of functions within the body. So we found very different signals of leptin, as well as these other metabolic perturbations. So we started to sort of label IIH as not just a condition of the brain and the eye. We started to say, well, actually, this is more of a whole body condition. This is a whole body that's not behaving in a normal way compared to others. And we're putting this under the umbrella term of a metabolic disorder. And what does this mean? Well, this is another study that we did, and this is a database study, which is something that the database study is something very interested that we've worked in collaboration with IIH UK again. But database work can be very, very powerful because you can get very big groups of patients together. And the bigger the amount of patients that you study, the more degree of certainty you have that your data is more accurate depending on the methodology. But generally, a big study is good. So this was a big group of IH patients. We had nearly 3,000 IH patients, and we matched them again, so the same age and gender and BMI to control subjects. And what was really important here was that we found that IIH patients had a higher risk of cardiovascular disease. And you can see that here. That's cardiovascular disease, nearly doubled the risk, a higher risk of heart failure, ischemic heart disease, so that's heart attacks, and of strokes, and a slightly higher risk of diabetes and high blood pressure. And this is independent of weight. So this isn't just a weight signal. This is something that is specific to IIH beyond what is caused by the weight signals. So again, this is really important. When this data came out and we spoke about it with Amanda and other members of IIH UK, initially it was quite alarming. This is something that people would look at and think, well, why is this happening? Do I need to be taking this up with my doctor? And we can talk about that at the end. But suffice it to say that it's important to do this research so that we start to understand what the future risks can be, because some of these things can be altered and changed, and where we can improve health, that's really important to us as clinicians. So what we would like to be able to move towards now is understanding that if we help alter cardiovascular risk factors when patients are young, can we improve outcomes when they're older? So I would start to say really that the IIH that we have traditionally spoke about is really the tip of the iceberg, and that risk of blindness that we perceive from the eye disease and the risk of chronic headaches is something that we have known about for a long time. But the research is now highlighting that weight distribution is very specifically around the tummy, that we have high levels of these androgens, particularly testosterone, increased heart failure and heart attack risk, and that actually the individual fat cells in a body of a patient with IIH behave in a different way and make them predisposed to lipogenesis and increased fat accumulation. So that's a lot about the causes and thinking about what's happening in the body of the patient, and it really speaks to this being a whole body disease. But for many of my patients, the majority of the time in clinic is almost spent talking about headaches, and so this really has also been a focus to understand what's going on in IIH headache. And this is a study, I'm sorry, some stuff's cut off the bottom, but I want you to focus on just up here. Headaches attributed to IIH are occurring during a period when we develop papilledema. And typically the headaches come as attacks that become more frequent and more severe. So you see these red spikes of increasing severity and increasing frequency of attacks. And there's a very clear relationship between pressure coming up and becoming more headachy. Sometimes after a lumbar puncture, you can either get low pressure headache or you can have a period of feeling a bit better, but a relationship to pressure nonetheless. But in many people, even once pressure becomes controlled in IIH, the headaches can remain problematic. And in this red box, there are some of the hypothesized areas for where we think sometimes people are more at risk of having ongoing headaches. And this would be people that have things like previous migraine or migraine as a child, or genetics of migraine, family history of migraine. You've heard from Ben Wakely about medication overuse can make you more likely to have ongoing headaches, but also if you have low mental health, again, weight has been shown to be related to being more headachy, and this thing obstructive sleep apnea, which is when patients often snore at night and have breath holding, and we test for this with our sleep doctors to screen for it. But the result of all of this is that sometimes when your pressure is very high, you have the high pressure headaches, but even when the pressure becomes low and normalizes, the ICP is resolving and the papilledema goes away, headaches can remain. And this is the characteristics of these headaches. The blue shows you that there's often a background sort of achy, dull headache, which is there all the time and is just a very much a nagging pain in the background. And that can be more severe or less severe in some people. But typically on top of that, there's also attacks of days where the pain is absolutely horrendous, and often patients need to lie down and they feel nauseated and they want to hide from light and noise. And these features are very migrainous, and there may well be very similar common final pathways in the brain between migraine and IIH, persistent post-IIH headaches. And again, these headaches are actually very difficult to treat. Let me just go back one. They're very difficult to treat, particularly if there's medication overuse, and particularly in those patients that have had shunts, because we also have the concerns about knowing how the shunt is functioning. But the message that I wanted to get over today is that often the characteristics can feel like migraine, and that probably migraine pathways may also be involved. So we took that hypothesis forward, and to explain it more simply, there are two places where we're currently looking at how we can treat headache. We can either hope to treat headache by directly reducing brain pressure, or we can hope to treat headaches once they become persistent and the pressure has settled by targeting the typical migraine pathways. So this is a study that was carried out by Andreas Yangu that some of you may have heard speak. He's been working in our research group for a number of years. And again, a lot of work from him and the patient group went into getting the study off the ground. In 2019, at the tail end, it was the beginning of the CGRP monoclonal antibodies being introduced for migraine. And Dr. Yangu screened and saw a lot of patients who had IIH, but their pressures had settled, their papilledema had gone away, and they still had headaches. And these headaches fitted the criteria, as I've been showing you, for chronic migraine. These are patients that had really been suffering a long time. Many of them had daily headaches, very, very severe. Many of them were using opiates and other medications to control their headaches, which again makes them harder to treat, but again is an indicator to you of really how severe their headaches were. And what was really, really gratifying to see was that this new medicine called arenumab, which is a CGRP monoclonal antibody, rapidly reduced the amount of headaches they were having each month. And it continued to do so for the time out to 12 months that we followed these patients up. So this is a great start, but it is only a start because this wasn't a formal randomized control trial. It was only patients on the medicine. And we know that there's a placebo effect in headache trials. And the first level of evidence is when you just do sort of case studies or open label data, but certainly now it would be very much something that we would be interested in doing, is taking this forward to a formal randomized control trial and seeing if we can formally evaluate these types of medications, these CGRP monoclonal antibodies, to help reduce the pain in IIH headache. I also wanted to think a little bit about lumbar punctures, and it's something that we've worked with IIH UK a bit. We've worked quite a lot about this, the traumatic, the trauma that often patients go through when they have a lumbar puncture, not just the physical trauma of the procedure, but the fear and the anxiety associated with lumbar punctures. And we've produced some articles and papers talking about the problems that there are with lumbar punctures in IIH. And one of the questions that is often on the table is, well, is there an alternative? Is there a good non-invasive and non-painful way of measuring brain pressure. And I wanted to highlight the growing use of optical coherence tomography in IIH, and then explain how we're moving towards reducing lumbar punctures. So many of you will be aware that you have your eyes scanned with an optical coherence tomography machine because it's very fast and objective. And this is a way of us measuring the back of the eye, what we call the papilledema or the optic disc swelling. And you can see in the normal circumstances, it's very flat. And when you're severe, you have this sort of hill appearance in 3D. And what we do is we can measure all sorts of different layers at the back of the eye, which gives us very, very precise numbers as to what's going on. So, for example, we could see a patient that had very minimal papilledema, and then the numbers have gone up as the papilledema has recurred, and then the patient gets better and the papilledema comes back down again. So what we've been looking at establishing is whether those measures, which are very fast and easy to do on the OCT machine, could help us predict brain pressure. So what, in essence, we looked at was whether the height of the papilledema, the height of this hill, could be put through our computer statistical analysis and could then guide us as to what the change in lumbar puncture opening pressure is. And that way, we would then need to do less lumbar punctures, which we know can be very difficult for patients. And this work was led again by Vive Vajek and by Miss Mollen, who was very, very carefully involved. And we did find that very significantly, we could use OCT to predict changes in lumbar puncture, particularly at 12 and 24 months. So for example, that optic nerve head height, if it changed by 50 microns at 1 year, that would predict a 5 centimeter of CSF change in the lumbar puncture pressure. So knowledge like this is not suitable to immediately use in clinical practice, but we are starting to go along a pathway now where we are emerging with technologies that I hope in the future will be able to negate or reduce the need for so many lumbar punctures. And certainly now in our clinical practice, we still need lumbar punctures at the beginning to make a diagnosis, but we increasingly now don't need to do lumbar punctures after that along the course of the disease, because we can use the OCT scanning to help us know what's going on with brain pressure and of course evaluate the eye. So this is a really useful technique. So I wanted just to finish up with something that's been quite an interest to us, and I wanted to let the patients with IIH know that the NASA team over in America are very interested to hear what's going on in IIH. So I don't know if you realize as patients with IIH, but not only are you at risk of visual loss in some circumstances, but astronauts are also at risk with visual loss, because during long duration space flight, they develop what we call spaceflight associated neuroocular syndrome, which is very much like IIH in many ways, in that they get swelling of the nerve at the back of the eye and papilledema, and there could be a risk, if it wasn't treated, of developing visual failure or visual loss. So the NASA medical doctors are very interested in understanding what happens in IIH, what treatments we use in IIH, and what levels of papilledema can be managed and how they can be managed. So all of the experience that we have had from seeing many of the patients, such as yourselves, over the last decade has been absolutely instrumental in helping guide a lot of the conversations that we're having with NASA. So just to illustrate here, this elevated intracranial pressure is something that they suspect is going on during long duration spaceflight, and they get fluid movements because of lack of gravity in long duration spaceflight. So both IIH and SANS get this problem with optic nerve swelling. And the reason that the astronauts worry about this is because, of course, if you get optic nerve swelling, what happens is, this is almost like an optic nerve here. It's like wires of an electric cable that get crushed. If they get crushed too much, then you can start to lose vision. And that's what we worry about in clinic. And that's why we keep an eye and we check the vision with the fields. But obviously that's more of a complex situation during space flight. But they do actually do OCT scans on the International Space Station now. And so we're able to get very good data about astronaut eye health. But the main problem for the NASA team is understanding how to treat this, and also how significant it would become if, for example, they were to do a mission to Mars where they would be exposed to microgravity for a much, much longer time than what they've currently been exposed to. So as part of sort of helping NASA with their Artemis mission, which is getting beyond the moon and missions out to Mars, we're quite significantly involved thinking about which therapies may be suitable for astronauts, and that information also may well be very suitable for the IIH patients. So there's a cross-pollination here where things that we're learning from yourselves in our clinic and our research is helpful to NASA, but also any research that will be going on there may also be relevant to us as terrestrial doctors to improve eye health and risk of vision loss. So my final slide and roundup. So at the top, I've written that hormones. What we know now is that the androgens are high in IIH, mostly testosterone, and we are evolving that to see if we can use that information to help us make treatments in the future, but much work needs to be done. The adipose, which is the fat tissue, is different in IIH, and it is prone to weight gain and lipogenesis. Eye scanning is a really key technique which is just growing and growing over the last decade, and we've now published to show that it can help us predict changes in brain pressure. The headache side, we are gaining our knowledge now, and we've shown that blocking this pain chemical called CGRP can reduce headaches, and we now need to do more research to look at how that occurs, how it happens, and to produce high quality evidence so we can make changes to clinical practice. And then my fun point at the bottom, that NASA are very interested in our research and in what is going on to patients' journeys with their eye disease and their headaches. And I hope that there will be useful cross-pollination of information between terrestrial IIH care and space medicine. And that's it from me. Thank you very much, Amanda.
Thank you very much, Alex Sinclair. That was a really, really interesting talk and fantastic to hear some of the amazing research that's going on out there and having it all brought together. There's quite a few questions on chat for you, and I'm going to work my way through them. Please do highlight anyone if I miss anything. There's a couple of questions which were linked about whether, if you are in remission, whether you still have elevated cardiovascular risk or a risk of the prediabetes that you were talking about.
It's a really, really good question. And I don't think I can say with hand on heart that we have the data to know exactly. What I would say is that anybody who has increased weight would anyway be at increased risk of cardiovascular disease and stroke. So if weight modification has put you into remission, then it is likely that you will have reduced your risk. But I think what our data is pointing towards is that patients with IIH, independent of weight, also have a risk within their bodies of having a higher risk of the cardiometabolic disease, the cardiovascular disease. So the hypothesis would be that probably when you go into remission, you're still at high risk. And therefore, if your GP is checking your cholesterol and your blood pressure and checking for diabetes and they're abnormal, these things should be addressed and treated early. And things like smoking should be stopped if possible, because again, that will lower your risk of cardiovascular disease. So just because you go into remission, I guess, would mean that you don't need to look for other risk factors for cardiovascular disease and treat them independently.
Thank you. There's a very good question and very interesting question here about whether you feel that in the future you will be able to anticipate IIH with hormone levels.
Oh, that's a good question. So I watch my colleagues in the polycystic ovarian syndrome research group. Professor Alt works very closely with us in our institute at the university, and they have really been at the forefront internationally of using hormone assays to make diagnoses of different rare and common endocrine diseases. And so I'd like to think that we maybe could aim towards that in the future, but at the moment we can't. But it's, it's a clear question on our mind.
Great. I've got a question here about your hypothesis or feelings about mechanistic links between adipose tissue, testosterone, and ICP. Now, I know that was kind of covered in the talks, but if you're able to touch on that again.
Absolutely, no problem. So what we have identified and published on so far is that the androgen, particularly the one that's called testosterone, is high in the blood and high in brain fluid in IIH. Now, we know that those hormones can be produced in a number of different places within the body. They can be produced in the ovaries, they can be produced in skin or in fat tissue. Some of the signals that we've got and the analysis that we've done has already pointed away from it being really an ovary-driven disease. So we don't think the ovaries are abnormal or producing these hormones. So therefore we're left with thinking, could it be the skin or the adipose tissue? So at the moment we think that there is a strong chance that the adipose tissue could be behaving in a way to produce more of these hormones. And some of the studies that actually one of the MD students in our group is looking at will start to identify if there is abnormal hormone production coming from the fat tissue. And all these little steps that we take help us to then think about, well, what can we do about it?
Okay, we're rapidly running out of time for questions, so I'm just going to very quickly, I'm sure people won't mind because of everyone's very interested to hear what you have to say, that we're going into the break very slightly. Whether OCT can detect changes in people with raised pressure who have already got severe damage to their optic nerve because of the pressure.
Yeah, no, it's a great question. We get asked this by a lot of clinicians as well. And, you know, the mantra when I started my neuro-ophthalmology training was that you're quite right. Once somebody had optic atrophy, and that would be a very pale disc, we were really taught that you couldn't swell again and you couldn't develop papilledema. But we've gained a huge amount of experience because we do these OCT scans in every single patient that comes through our clinic, and we've been doing it for a very long time. And what we clearly see is that in some of our patients who have had optic atrophy really quite severely affecting their retinal nerve fiber layer, we certainly see them swelling again and can pick up the papilledema. Ms. Mollen, do you want to comment any further on that? But I would say we can certainly see swelling.
Yeah, we can. We published a nice little series proving this point, because the community out there believe that you know, that you can't swell your nerves again, but the OCT has such good resolution, and in some patients it was easy to see on the slit lamp, but in other patients it was really OCT that picked it up, and it led to different treatments. So I always say to my colleagues to make sure that they continue to follow patients and follow them with OCT.
Absolutely.
Great. I'm just having a quick look just to see that I have covered all of the questions there. There was a question via email earlier on today which asked whether we could ask you about any potential links between IIH and chronic fatigue syndrome or fibromyalgia, whether there's any research you know that potentially links.
Yeah, I mean, it's difficult, but these conditions often are found in the same patient. I'm going to cough, sorry. So we sometimes find that body pains, chronic fatigue, low mood, chronic back pain, and Ehlers-Danlos and POTS can all come in similar types of patients. I don't think we know enough as a community to really hang our hat on saying why, or if this is just coincidence, or whether these types of patients are more predisposed to all of these types of conditions, but it's certainly something that we observe. And at the moment, although we can't really say the why, what we certainly do is take into account if you have multiple diseases, how we manage you. So for example, some medicines that we use are helpful to both fibromyalgia and chronic migraine. So we might choose one that would be suitable for both rather than one that wouldn't help the other. So we try and be mindful of all the other diagnoses when we choose our treatments, but I can't say exactly why.
Thank you. I'm hoping that I've covered all of the questions in the chat now. Oh, there's one quick one that's popped up. It's just about, is there any links between the menopause and changes in your IIH, so specifically remission or exacerbation?
So traditionally, I think the disease is much more commonly, the incidence is higher in the younger population who are pre-menopause, that's absolutely for sure. We do still see patients sometimes with active disease post-menopause, so we can't say that in all people it will make a difference, but very often the disease becomes more burnt out and you may be left with some of the other sequelae of IIH, such as the persistent post-IIH headaches post-menopause, but the actual pressure will have settled. Mm-hmm. Hormonally and mechanistically, it's fascinating about how changes in hormones may impact on your IIH and your brain pressure regulation, and we haven't got there yet to understand or pick that apart, and nor has anybody else internationally.
Great. Just to give a phenomenal thank you, I can see on the chat and also on other social media sites, is just to say that people really appreciate having all this wonderful research carried out, and also the sharing of that information with them, that it's great for people to hear that these things are happening and that there are potential changes in the future. So thank you very much.
Thank you, Amanda, and thank you to the patient group. And we have got a lot more kicking off in the autumn and spring coming up. So we will be coming back to you all and telling you about what's starting and how we'd really like to engage and get the community to support us as we start new trials.
Fantastic. Well, we're going to take a short break now, only just a 5-minute break. But after that, we have Dr. Mark Thaler joining us talking about IIH in pregnancy. And then I've got the last slot talking about obesity stigma. So we'll just take a very quick 5-minute break and we will be back. Thank you.